for the postgraduates and the doctors who are actually finished post-graduation and just starting to do their cataract surgeries, how to maximize what you have already learned and how to start doing your cataract, mainly SICS or FACO, whichever it is. So we'll go with the first talk, that is the SICS basics, the must-read books. The topic will be dealt by Dr. Vaishaki Prasannan. She is the pediatric surgeon at Pallarivattam Chaitanya Eye Hospital.
Very good morning to all, very good afternoon to all, and welcome to the first session of today's IC. Starting with, you should always know what you do. We know that the eye sees what your mind knows, and hence this is the basic dictum before starting any surgical training. You should be well thorough about the surgical anatomy, the steps of the surgery, instruments to be used in the surgery, when to modify each step, complications to be anticipated in each step, how to identify complication and manage them. And how to learn this? We have textbooks and literature, classes, observing our seniors, colleagues and even juniors, a thorough wet lab practice to improve our surgical hands, videos and discussions. Though videos and discussions are the fastest and more reassuring part of learning these things, you should be thorough with the basic principles of each techniques to be used, and for that textbooks and literature play an important role. In this session, I'll be briefly discussing about each textbooks which you can refer to for learning basic principles of cataract surgery. First one is Henderson's manual small incision cataract surgery book, which gives a brief detailed description about the instruments, the surgical anesthesia, steps of surgery with diagrams, complications, their identification and management. This SICS book by Ashok Garg et al. Is an elaborate book which starts with anatomy of crystalline lens, etiology and classification of cataract, followed by principles of sterilization, anesthesia, steps of surgery. It also explains the dynamics of each step, and it finally mentions about the recent advances and special techniques. This CME series by for manual small incision cataract surgery is a brief textbook which is very concise, and this will help you to brush up each steps of cataract surgery and about the management of complications. Manual small incision cataract surgery by Aravind. This is a brief book which explains in details about the instruments, surgical steps and complication identification and management, and this explains each step using diagrams which will be very easy to use and understand for the PG students. And coming to this elaborate textbook on cataract surgery by Sternert, and this starts with the pathology and classification of cataract, is explained about different methods of classifying cataract, followed by anesthesia for cataract surgery, IOL power calculation, different IOLs, and it also explains using diagram steps of cataract surgery and how to manage each special case, including intumescent cataract, use of toric lenses and small pupil. For phacoemulsification surgery, this should be your Bible, the book by Siebel. This explains in detail the phaco-dynamics as well as each step of phacoemulsification surgery, and book by Hashman et al. Apart from that, there are a lot of online sources for learning. The OroTube channel by Aravind Eye Hospital, Pondicherry, it explains in detail surgical techniques as well as management of special cases and complication management in case of cataract surgery. Understanding the mechanism of each step in learning helps in learning as well as practicing them in a better way. It will boost your confidence, and knowing the dynamics of cataract surgery will help you to do cataract surgery better, as well as it will help to get a good outcome for the patient as well. Thank you.
Thank you, Dr. Vaishagi. I think we'll finish all the sessions and then open for discussion. So the next talk will be by Dr. Raki de Cruz on learning from your mistakes and keeping a logbook. She is a consultant phaco surgeon at Chaitanya Eye Hospital, Kollam.
So, good afternoon, everyone, and this is a session on how to learn by yourself from your mistakes and keeping track of your mistakes and learning SACS better way via a logbook. So, the only real mistake is the one from which we learn nothing, said by Dr. Henry Ford. So, how to learn from our own mistakes? You have to reassess your surgical steps and grade yourself along with your trainer. Review your surgical videos and learn from those mistakes. Keep a track of your improvement via a logbook. There are different systems for surgical proficiency available, which includes the ICO Oscar system and OASIS system. So what happens in Kerala and in most of the places inside the India is that an ophthalmology resident should be at least confident in SACS independently at the end of surgical residency, which does not happen. And the main way how a surgical competency is assessed is by auditing the surgical case's post-operative outcome. That is, they assess only the visual outcome post-operatively as a criteria to know whether that surgeon is proficient or not, but not the stepwise surgical performance. I think that is not right. The right way to do it is via the ICO rubric system. The ICO rubric system is called as a rubric because it breaks down an operation into separate steps and sets clear guidelines for different level of skill with which each step can be performed. So this will help to track your performance as well as to keep your record. So this paper by Ashok Grover and Santosh Hanavar has also said that this ICO rubric system should be incorporated in the NMC based ophthalmology curriculum. So this system is available not only for cataract, it is available for almost all the specialities. So this is an example of ICO rubric system available easily online. Just download it. So it starts with draping up to the end of the surgery. So just look at one of this corneal entry. So if you are hesitant with the keratome entry, you are unable to extend the internal wall. You can assess yourself. There is shallowing of the AC in between. That means if you have a trainer or a senior with you, they will give you a score of 2, or else you yourself can give you a score of 2. That means you are just a beginner, novice. And then goes to the second step where you can enter AC with a difficulty. You create different plane. That means you are still a beginner, but you enter at the right plane, able to extend, but you have to repeatedly use viscoelastic and your internal wall is still irregular. You are at a stage of an advanced beginner. That means stage of 4. And if you are competent, every step will be smooth. There will be a self-sealing good SS wound. That means you have become competent. So from this you will know what is expected from you at each and every step. You can grade yourself, or if you have got a trainer, that person can also help you to grade yourself. This is not only available for the steps, it is available for the global indices like the eye positioning by the surgeon, the iris protection, the overall speed and fluidity of the procedure. It is available for phaco also, a very detailed stepwise, so that you will know what is expected of you with phaco also. Then there is another scoring system which is known as the OASIS scoring system, and here there are 3 aspects. They grade your preoperative, intraoperative and postoperative aspect. So what happens postoperatively? They will look at the astigmatism that you have created, the rate of complications of individual residents, the cohort of patients, like if you have operated on a pseudoexfoliation patient or not. So everything will be assessed. Now, if you don't have all of this, there is a simulator based assessing system which is known as IC. But this simulated assessment model correlates well with the real life metrics and can thus work as an effective tool for surgical competency. This is available as an app also. You can download, you can practice in that, and you can grade yourself. Now the next step, that is learning by reviewing, that is by a surgical video record. This is one of the pictures of my friend Sunitha itself operating. So what all we can learn from this? You can learn how the surgeon holds the instrument from outside. You can also learn what is her positioning on the microscope from the outside, right? So all these things you can learn from outside, but you have a surgical video recording system. That is the best way. Record your initial surgeries and try to review them with your mentor or a senior. Try to find out the steps that went wrong, ask for suggestions. Make it a habit to rewatch your own videos. Even if now you are an advanced beginner or you are practicing independently, make it a habit to rewatch your videos. You will yourself find out several mistakes. So watch with senior surgeons instrument handling and hand rest position from outside also and learn. So logbook is a very crucial if you are a postgraduate, because this is very important when it comes to applying jobs internationally as well as fellowships internationally. It should be properly signed and sealed by the director of institute. So this is my own logbook. So this one also follows the ICO rubric system at our place. So here, this is one of the pages of a FACO that was done by me. You can see the trainer gives a score, the trainee also gives a score. And the trainer gives comments like overall fluidity is not good, should learn the cracking properly. There are difficulties with proper power modulation. So that is like, you know what steps you have to improve, what you want to refocus on. And if you don't want to write it down, you can actually create an Excel logbook in your phone. This is the one I had created when I was doing my surgeries. So this is an SACS logbook. Just enter the demographics, preoperative visual acuity, what is the lens grade, what were the preoperative things like the patient had brown cataract, pseudo exfoliation or not, which surgery was done, what was the IOL power, what were the difficulties. This you can write soon after your surgery. Surgery കഴിഞ്ഞ് ഇറങ്ങുന്ന ഉടനെ തന്നെ ഫോൺ ഓപ്പൺ ചെയ്ത് അവിടെ എഴുതുക, അല്ലെങ്കിൽ യു വിൽ ഫോർഗെറ്റ്. സോ ദാറ്റ് വിൽ ഹെൽപ്പ് യു ലൈക്ക് എ ഗോ ടു ഡയറി ടു നോ വാട്ട് സ്റ്റെപ്സ് നീഡ് ഇംപ്രൂവ്മെൻറ്റ്, വാട്ട് ആർ ദ തിങ്സ് ലൈക്ക് ചില ടിപ്സ്. അപ്പോൾ നമ്മുടെ ട്രെയിനർ പറഞ്ഞു തന്നതാണ്, ഇവിടെ ഇച്ചിരി കൂടെ വിസ്കോ ഇട്ടിരുന്നെങ്കിൽ എളുപ്പമായിരുന്നു ഇൻറ്റേർണൽ എൻട്രി ചെയ്യാൻ. അപ്പോൾ ആ ടിപ്സ് അവിടെ ഒന്ന് എഴുതി വെച്ചാൽ ഇഫ് യു ക്യാൻ ഗോ ബാക്ക് ആൻഡ് ലുക്ക് അറ്റ് ഇറ്റ്, ഇറ്റ് വിൽ ബി ഈസി ഫോർ യർ നെക്സ്റ്റ് കേസ്. So you can actually just download Excel in your phone and try to create a logbook like this also. This was another one which I created for FACO also. So if you don't want to make your own logbook, this Royal College of Ophthalmology site is having an online ready-made logbook, iLogbook, which can be downloaded easily and you can start entering in that also. And there is another book of logbook by A.K. Kurana sir, which is also available. So mistakes has the power to turn you into something better than you were before. So person who has never made a mistake never tried anything new. So try to make mistakes, but try to learn something from that. Thank you.
Thank you, Dr. Aki. The next talk is by Dr. Manju M on training yourself at wet labs, bullseye versus goat's eye. Madam is a glaucoma surgeon at REI Hospital, Thrissur.
Good morning all. The topic also is on hands-on precision, enhancing the surgical skills through wet lab training. So what's a learning curve? A learning curve in a surgery is a graph that shows how a surgeon's performance improves with experience. So you can see in the learning curve, there is a slow beginning and there is a steep acceleration. So if you can gear up this slow beginning phase, then there can be there is a lot of time that you can save during the next phases. So how to accelerate the slow phase in a learning curve? That is important. So first is by breaking down the complex skills into simpler versions, simple steps, simulation training, and also by a timed repetitions of the same. So one step that helps you in that is a wet lab training. So the advantages of a wet lab training is that you can be better equipped on the real eye. It can enhance your psychomotor skills. It can enhance your eye-hand coordination, and it is done in a less stressful environment, which helps you to do better. So these are the steps for setting a wet lab. you should have a defined training objectives, like what all surgeries you are planning, like phaco, trab, or any other surgeries, or whether it is retinal surgeries, what all you need in this wet lab. Realistic stimulation models if possible, and high quality equipments, microsurgical setups and visualization technologies, audiovisual if possible. Priority to safety and sterility, always give priority to safety and sterility, and continuous feedbacks and skill assessment is also needed. So first, better to start with the lectures and then do the wet lab practice. And when you when you do the surgery, you may feel some steps that is difficult, and if possible, do the wet lab training for those difficult steps, which is focused on these steps, and which will improve you in the OT surgeries in the next session. And if possible, have the video discussions. This is the OT wet lab which we had in Aravind, and you can see there is a microscope and with visualizing systems, and there is a space for training and giving classes, and also there are proper safety, and there is air conditioner for the air safety, and there are disposing. So the safety should be there, and sterility should be there, and provisions for class. So microscope with a side scope camera, and connect, if possible, connected to the TV screen, and phaco machines with tubings and expandables. And these are the instruments, equipments and instruments. And eyeball fixing devices. For the proper fixation of the eyeball, you need, for better training, you need fixation properly. And select artificial anterior chamber, and for the suture practice, and for PKPs if you need that. And this is something which I did during I did a glaucoma fellowship, so we had to practice suturing. Suturing is very vital. So each week, each day, 30 minutes you need to do suturing. So this is week 1, 2, 3 and 4 which I did. So as you time passes, there is an improvement in the speed, there are more sutures. So this is intensive training, right? For the trap, suturing is a vital ingredient. Like that, whichever is the complex step, try to do it regularly and excel in that. And for that, you need eye preparation, rejected units of donor corneas and eyeballs from the eye bank. SICS or phaco practice eyes can be bought, or animal eyes like god's eye, bullseye and porcine eye. What are the differences? God's eye is little bit difficult to make the rexes. Lens thickness is twice as that of the humans. Soft cortical lens for the trenching, and there is always a blue reflex. Bullseye sclera thickness is more comparable to the humans. So bullseye are preferred for tunnel making. Porcine eyes are thick, more elastic and viscous, ALC mimicking pediatric anterior lens capsule. Few differences are: smaller eye, god's eye is smaller eye, and that is easy to handle, which is a little more bit similar to the human eye. Bullseye is larger and needs more area to practice and to fix. Thinner corneas resembling god's eye have thinner corneas, other one thicker corneas. Lenses are smaller and softer, and the bullseye lenses are harder and denser, and it's easy availability of the god's eye than the bullseye. But if you want to make a practice on the tunnel making, bullseye may be better than the god's eye. And these are few corneal DMEX and DSEC which is done on the god's eye. So if you want to do any corneal procedure, it is better to get a god's eye. And if you want to do the tunnel making, suturing and all, bullseye is better because you have more thicker sclera and more area to practice. And god's eye, so if you are getting the eye, get at the same morning and stored in the nice box and use on the same day. And if you can inject formalin into the vitreous cavity by the transscleral fluid, it can increase the IOP, keep the eyeball tense for a longer duration, and it can make it ideal for training. This study, they have injected it. If you want to know how to inject and all, you can refer into this paper. And you can practice steps like peritomy, tunnel making, capsulorhexis, And you can also practice capsular access in these boxes, IOL boxes. By drawing the circles, you can limit the area and to have a controlled practice of the capsular access. And phaco, in the wet lab, you can always practice footstep practice and have a better eye-hand coordination also. So the take-home messages are safe skill development. Wet lab helps in the safe skill development and can enhance the anatomical understanding and helps to transit you from the theory into the practice, mastery through repetition and adaptation to new technologies. Wet lab practice is where confidence grows and precision becomes a second nature. Thank you.
Thanks to Dr. Manju, that was indeed very useful. And we are going to our next talk, which is the Getting the Right Patient for Your First Case by Dr. Sunitha M. Kuriakos. She is currently a consultant phacosurgeon at Lotus Eye Hospital, Cochin. Over to you, Sunitha.
Good afternoon, everyone. So I'll be discussing how to get the right patient for your first case. So always the aim of a study of a surgery during our inexperienced stage is to have a safe surgery more than a perfect surgery. So we are not concerned about the actual visual outcome, but we need a safe and a good surgery. So we must be ready to learn, unlearn and relearn of what we have already done. So always go by the book. That is, never miss or skip a step. Don't take any shortcuts. So first important thing is history taking and the systemic examination. Always select a cooperative patient. So the question is, how do you know whether the patient is cooperative? My sir used to say, when you talk to the patient in an OPD, if the patient talks more and you listen, that means the patient is not cooperative. If you speak more and the patient listens, that means you have a good patient. So the age group that we prefer is between 50 to 55 years. Ideal case. That is less than 45, they are younger, they are more concerned about the complications, they are more apprehensive. If they are more than 60, they are harder cataracts, so it will be a little bit difficult for a beginner. And select people who have non-demanding jobs. That is CAM patients who are ready to do a free surgery, probably a female that doesn't have to go out, make a living. And always ask about the comorbidities. That is, choose a patient who can handle a prolonged surgery. Your initial surgeries are going to take about 45 minutes to 1 hour. So you need patients who are cooperative. They'll lie down for you. So rule out all the uncontrolled diabetic, hypertensive people, any patient with a cardiac problem, any history of stroke, make sure they have stopped all their anticoagulants, any psychiatric illness patients, any patients on tamsulosin that can give you a floppy iris during surgery. Always rule out local infections. Look at the lid, look at their tooth, look at their foot, because all these are common places for ulcers and infections. And check if they can lie supine. That is, when you do a pre or post scan, you can just put a drape on their face and check if they can tolerate a drape and lie supine for almost 45 minutes. So any asthmatics, any claustrophobics, patients with severe scoliosis who can't lie down straight supine, any patient with severe head nodding, Parkinson's patients, just rule out, don't take those patients. Also, when you make the patient lie down, you can also access the AC depth. Sometimes the lens will fall back and give you a little more deeper AC compared to when the patient is on the slit lamp and sitting. And any frontal bossing, these will give you a little bit difficult in handling and actually going into the anterior chamber. Always take a detailed ocular examination. Please avoid one-eyed patients. We don't want people to with one-eyed or low vision patients to get operated from us. The next one, any history of trauma. You have to ask for it, otherwise they will not tell you. Any previous eye surgeries like a vitreoretinal surgery, a glaucoma surgery, any previous cornea surgeries, all that will make it difficult for you to do your cataract surgery. History of uveitis is very important because intraocular recurrent infections, any iritis, uveitis, will have complications post-op because this is a prolonged surgery. You can handle the iris, you might touch the iris. So we don't want a chronic iritis patient post-op. Next, any high myopes, hypermetropes, even high astigmatism, better to avoid. Complicated cataract like secondary to a trauma, secondary to iritis, all this we need to avoid. We cannot predict how the eye will behave once you open the eye. Always check for the fellow eye. As I already told, one-eyed people just avoid. Check for their surgery notes. See if there is any signs of iris chafing, any PCR had occurred, there is serious intra-op complications like iris prolapse, and what type of IOL has been placed, like a 3-piece, an iris claw, or an AZ IOL. So we expect the same complications in the eye that we are going to operate also. Always do a detailed adnexal examination, check for the ducts, check for the intraocular pressure, check if there's a deep eye socket, if there is frontal bossing, look for lid swellings. We need to evert the lid and look for it, only then we'll get it. If there is severe MGD, squeeze and flush it out, give topical steroid antibiotic ointments, give a course of oral antibiotic, and only then take for surgery. Then always do a detailed dilated slit lamp examination. You need to see the patient dilated and not the sister who is giving you the case. Check for the cornea. If there is severe dry eye, scarring, check for the AC. If it's shallow, if there is a post-TIAC PI, that patient might have an iris prolapse because it is a floppy iris. Then iris also you have to check for pseudo exfoliation. Don't take pseudo exfoliation patients. Even if on a sitting position on the slit lamp there is no phacodonosis, but the zonules might be weak. Once you enter the anterior chamber, you start your excess, the lens and the bag might start to shake. Rule out non-dilating pupils, posterior cynic, any floppy iris. Cataract, don't go for soft or too hard cataracts. Check for phacodonosis. Check for phacodonosis and avoid a PPC. Always ensure you have good local anesthesia. A well, soft, anesthetized eye is the best option. You have to wait for 20 minutes after the block before you start your case. Just blocking and then shifting the patient, the eye will be hard. Always drape well so that all the lid is away from the field. Avoid tight lid speculums. The globe will become hard and the intraocular pressure will be high. The microscope settings also, do your IPD, know your IPD before the surgery, set it and always neutralize the optics of the eyepiece. Illumination, you have to know how to put it in a bright, how to do a retro illumination. You have to know your microscope. The stool height, that will help in the depth perception. You need to know the foot pedal adjustments like how to up and down the focus, how to zoom in and zoom out, and always check your probes, whether the machines are working before you start the surgery. As you know already, you should know your instruments. They should be sharp, not blunt and already used ones. You should have that pen holding technique you must know. Keep ready all the ones that are needed to manage a complication like venas, iris repositors, sutures, vitrectors. And always keep talking to your patient when you do the surgery. That will help the patient relax. Also, it will help you to relax. And explain the completion of steps like, okay, I've finished the cataract extraction and I'll put the IOL. It's just going to get over. I'll finish it in 1 minute. The patient is also reassured. Always go by the book. Do not skip any of the steps. Always stay in the capsule. We need an adequate capsular excess of 5.5 to 6.5 mm. Always follow one mentor. You stick on to one person's teachings. Don't follow everyone who talks until gives you advice. Video recording already has been discussed by Dr. Aki. And always keep help in handy. Don't be overconfident. Keep your mentor with you. Just trust your trainer. Listen to your trainer. And do not hesitate to stop and withdraw if the things go wrong. If the trainer tells you to stop, that means he knows it's going to go wrong. Just stop. So this is the ideal first case. An age between 50 to 55 years. There's no history of trauma or surgery. The IOP is normal. A patient is cooperative. There is no deep socket or frontal bossing. He's not a high myopes, hypermetrop or astigmatic patient. You have a good pupillary dilatation, grade of nuclear sclerosis 2 to 3, and a well anesthetized eye. Thank you.
So we have our next talk on SACS beginner's perspective. by Dr. Aradhi V. Panikar, and she'll be talking. She's currently working as a consultant cataract surgeon at Precise Eye Hospital, Mavelikara. Over to you, Dr. Aradhi.
Thank you. Good afternoon. I would like to take you through SICS from a beginner's perspective. The anesthesia can be peribulbar, retrobulbar, or subtenons, and the initial steps include preparation and draping, putting a bridal suture, doing a conjunctival peritomy, sclerocorneal tunnel, capsulotomy, hydro procedures, nucleus prolapse and delivery, and the final step is IOL insertion. We'll go through each step one by one. Preparation and draping. Betadine scrub should be started and then centrally and then move peripherally. Do not return back to the eye. The betadine is allowed to dry up for 2 minutes. Elevate the superior eyelid and place the drape directly over the eye. You should get all the eyelashes under the drape. The putting a bridal suture is one important step, and it is mainly done to maneuver the globe, and it also provides counter traction during nucleus delivery. It is done with a double angulated forceps and held with tip pointing face down towards conjunctiva, and superior rectus is fixed and held with the help of the toothed forceps. You should move the muscle from side to side because we have to test hold of the muscle and make sure that the globe moves accordingly. This is usually done with a 4-0 silk suture. The complications that can happen during bridal suture is globe perforation, bleeding, muscle injury which can be laceration or avulsion, and post-operative ptosis. Next is doing a conjunctival peritomy. This is opening of conjunctival flap. The forceps is held with a non-dominant hand and conjunctival scissors with the dominant hand. The flap is based towards the fornix. This should be initiated at 10 o'clock. And the ideal conjunctival peritomy exposes the blue limbal zone without any overhanging conjunctival epithelium. The peritomy should be approximately 8 mm in length and 4 mm in width. After a proper blunt dissection, there should be bare sclera at bed without any islets of tens. Next, we can do a cautery that is wet field bipolar cautery, which allows visualization of instrument during tunnel creation. This is mainly done to minimize the bleeding into the anterior chamber, both intra and post-operatively. The disadvantage of cautery includes scleral thinning and scleral necrosis, poor wound healing, etc. The ideal cautery should be a point cautery done to scleral bleeders only. The cautery of the limbal blue zone bleeders has to be avoided, and it should not be applied after scleral incision and tunneling. The paracentesis, that is side port, should be put 1 to 2 clock hours away from the internal corneal incision. It helps in AC depth maintenance, staining the anterior capsule and cortical cleanup. The staining the anterior capsule, initially the air is pushed into the anterior chamber. Trypan blue is used to stain the anterior capsule and then it is washed out. The anterior chamber is maintained with viscoelastics. Next is a main important step of SICS cataract surgery, that is self-sealing cataract incision. The external scleral incision is made with the help of a surgical knife or blade. The tunnel is made with a crescent knife and the internal incision with a keratome. The external incision should be 1 to 2 mm posterior to the limbus. This can be in various shapes like smile, straight, frown, chevron, and inverted batwing incision. The incision depth should be at ideally half to 3/4 of the scleral thickness, and the sclerocorneal tunnel construction is done like sweep the incision with the tip of the crescent blade to make the incision smooth, non-ragged, and of uniform depth. You have to judge the depth of the incision by looking at the blade transclearly. Now propagate with the swiveling action in both sides. The lateral swiping movement should be done so that the tilt of the blade is along and equal to the contour of the globe. If it is going too superficial, you can go for a buttonholing, and if it goes too deep, you can get a premature entry. Now extend the tunnel up to 1.5 mm into clear cornea. Use a bevel down keratome and a dimple down technique to enter the anterior chamber and create a third plane for a valve defect. Once the anterior chamber is entered, keep the keratome parallel to the plane of iris and extend the tunnel with forward cutting movement. So this is the measurements of the external incision, ideally 6.5 mm in length, 1.5 mm from the limbus to the incision, and internally also 1.5 mm. The internal incision should be around 7.5 mm in length. The complication that can happen during tunnel is irregular incision, buttonhole, premature entry, and DMD. Next is a very important step, that is capsular opening. That is, opening the anterior capsule should be stable enough to prevent the anterior capsular tears from continuing to the posterior capsule. Should be of adequate size, can be done as continuous curvilinear capsulorhexis, can opener technique, or envelope capsulotomy. Done with instruments Pierce Hoskin or Colibri forceps, bend cystitome needle, capsulorhexis forceps, the AC maintained with viscoelastic. CCC is the most commonly done procedure. Puncture is made in the central anterior capsule and it is directed peripherally, either in a clockwise or counterclockwise fashion. The tear is held in a circular fashion. The control is achieved by grasping 2 clock hours away from the free flap edge, closest to the leading fold of the capsule. The good thing about CCC is that it allows for an easier cortical cleanup, promotes stability and centration of the IOL, resists anterior capsular radial tears, safe hydrodissection, and in the back lens rotation. The bad thing is it needs more experience to master. Larger CC can promote IOL dislocation from the bag, and small CCC you'll have difficulty in prolapse of the lens into the anterior chamber, and it requires excellent visualization. The can opener technique is done. The good thing is that it is easier to learn. Learning curve is short. High number of tears shares forces, thus reducing the chances of radialization. But bad thing is that you will find difficulty during the cortical cleanup. That is, capsular tears tags will be difficult to differentiate from the cortex. Hydro procedures can be done as dissection and delineation. Dissection is conventional hydrodissection and the cortical cleaving. Conventional is separation of the superficial cortex from the epinucleus, and the cortical cleaning is separation of cortex from the capsule. After doing hydro, while doing hydro, you have to look for the advancement of the fluid. If there is anterior movement of the nucleus, stretching of the CC and deepening of the anterior chamber. The mistakes mainly done is difficulty. You'll have difficulty in tracking the capsular margin, and if you inject hydro without seeing the margin, then doing a hydro through side port in a viscofilled eye, less fluid injection can result in an incomplete hydro, and more fluid injection can go for chances of PCR. The hydro delineation is separating the outer epinuclear shell from the endonucleus. This is done mainly in case of PPC. Nucleus management can be nucleus prolapse and nucleus delivery, and adequate capsulorhexis should be done after a proper hydro dissection. One pole of the nucleus tilts forward, then you can hydro or visco cannula is manured underneath the rhexis margin. Then the equatorial edge of the nucleus is dislodged out of the capsular bag. The whole nucleus is rotated into the anterior chamber. After that, very important step is cortex removal, which is done with a Simcoe cannula. And initially, you tackle the most accessible parts, such as the inferior and the nasal. After that, the cortical material floating into the anterior chamber is aspirated. Then the cannula is placed beneath the capsular margin. Cortex is engaged and it is brought to the center of the pupil. Then only aspirate. Don't aspirate it at the edge. When pulling the cortex from behind the iris, to and fro movement is done to loosen the cortex from capsule at the equator. Then the final step, the IOL insertion, fill the anterior chamber with visco, hold with McPherson near the upper dialing hole and to introduce into the tunnel. After leading haptic enters the AC, you tilt forward and direct towards the 6 o'clock. Then keep pushing till the leading haptic is completely in the bag and the lower dialing hole at the pupillary border at the 6 o'clock. Now gently release and withdraw the forceps. Grasp the trailing haptic with McPherson forceps, rotate the lens, and then as you tuck the trailing haptic under the edge of the capsule. Now, to confirm whether it is really in bag or in sulcus, if it is really in bag, you can see the stretch lines in the center of the posterior capsule and also visualize the shiny appearance of anterior capsular rim over the haptic. Wash the viscoelastic, check for the wound integrity, generally tap on the cornea or the limbus opposite to wound with hydrocannula, hydrate the side port. After that, you can inject the intracameral antibiotics. Check the wound again. The indications for suturing are a leaking tunnel, premature entry, pediatric patient, or posterior PCR with vitreous disturbance. Finally, you can give the subconjunctival injection, remove the speculum, recheck the eye, apply ointment, and keep an iPad and send the patient. Thank you.
Thank you, Dr. Arati. Any questions from the audience? I think we'll close the session. Thank you everyone for your